Okay, let's move on to page 170 on the integrated performance report. So Claudia Griffith, our Chief Delivery Strategy Officer, you can assume that the board has read your report, but are there any key points that you want to highlight from this?
So I think this is the third time we've brought this report to the board. I think it continues to evolve and hopefully people can see the evolution of it as we move forwards. The intention for the next version of the report is to start to incorporate some of the measures from the population outcomes framework as well, so that we're taking a truly holistic view of performance across the system. The escalations that are contained within the report will touch on many of the areas that we've already spoken about, so hopefully it gives you a sense of what's coming up through that report. It is identifying the issues that we know we have as a system, and there is work going on across all of these areas. We've also tried to draw out some of the areas where we're seeing improvements as well, so taking on board the feedback that last time it can read as quite a negative report otherwise because all it focuses on is the escalation, so we've tried to draw out those areas of improvement.
Great, thank you for that. So I think as we've discussed before, the integrated performance report is just to provide us a triangulation point. So actually most of these, in fact all of these issues should be coming through our committees anyway. So we wouldn't normally be expected to work through this line by line. What we would expect though is that if there are any particular areas or themes or any general levels of concerns that we would require a committee to review in more detail, they're the type of issues I'd like to just draw out in this particular section. So Louise, I think you wanted to kick us off.
Thanks, Chair. And yes, it's the Finance and Outcomes Committee that will mainly be taking assurance on and doing deep dives in any areas that the board would like us to on performance. So I did have a question on healthcare associated infections and the rise there. Can that be explained a bit more in terms of why there's an increase and what actions we're taking to reduce it?
Would that be easier for Alison to answer that as our Chief Nursing Officer?
Yeah, no, thank you. So obviously we monitor all health associated infections across the system and with individual providers. What we are seeing, there is a increase nationally, and the national team and regional team are doing some work to try and understand why that may be and what may be causing that. Having said that though, through our Quality and Patient Experience Committee, the Chair asked for an updated report to be presented next week in terms of the assurance that we've got around provider plans and what they're doing to mitigate some of the risk, both from a training and oversight perspective, but also around some of the actions they may be taking around estates and things that they think may be contributing to the increase in infection rates. Some of it will be because we know our providers are fully occupied, so often over-occupied as well. So that may be one of the things, but there is a report that is going to the Quality and Patient Experience Committee next week, and we'll be able to report back to board the assurance around that or any further work that we think we might need to do in this space.
Okay, Sue, were you wanting to follow up on that?
Only to say, because of the national and local increase, we've asked for an additional report to come, particularly focusing around cleaning and estates, etc., etc. So that's coming next week to the committee.
And we'd therefore get that back at the board at the next board meeting, wouldn't we? Your assurance report on that. Okay, thank you for that, Alison. Rahul.
Thank you, Chair. I have a general question. Based on the report, there are areas that talk about validating data quality improvement plans. And my question is, have we undertaken an assessment of our providers in regards to data integrity audits that they've undertaken for their data to ensure that we do have trustworthy data coming through into the IPR?
Yeah. So there is a rolling programme of work that our BIT undertake in terms of assessing data quality, and they have an audit process that they follow in terms of understanding the quality of the data that's coming through. And in particular, when any new measures get incorporated into reports, they undertake a process of audit to understand the data quality issues that there may or may not be. I think it's fair to say that there are areas that we know have where we've got more challenges around data quality. So some of the community data sets, we're working in, there's a national programme of work around improving the data quality around community data sets. And we also know that when we get into spaces such as trying to gather data around, for instance, BCSE services, again, smaller providers have a greater level of challenge in providing robust data quality. But yes, there is a data quality process that our BR team run with regular reports.
Good, thank you for that, colleagues. There was just one thing from me, and it's maybe a question actually for James, if that's okay. I welcome the evolution of the report to include the Sussex Population Outcomes Framework, but I think what the board does not need is just another 10 pages of 109 individual measures. I think it's the interpretation of that that is going to be quite key. And so, as that's going to become a part of this report for the future, I just wondered how you wanted to address that.
So I think what we'll do is we'll take that comment on board, we'll refine the information, but make sure that we respond to the population health outcome piece and how it's translated into improvements in health population that we observe.
Yeah, that's great, because I think actually linking it back to the health inequalities, because I'll be honest, from a personal point of view, I don't find the health inequalities page that helpful, because it doesn't come very often, and it feels quite static as a set of measures, whereas I know the population outcomes framework is much more dynamic than that, and I think really trying to understand what the population outcomes that we're aiming to get, or where the inequalities exist, I think would tie it all together. And I think understanding that from as a non-clinician, from that clinical perspective, will be genuinely helpful, I think, for the board to understand that. Okay. So, with that in mind, can I just say, are we content with that? I think our governance process, we've picked up a number of the issues already through the escalation reports from the committees. That shows to me that the governance is working, so I think that's a good thing. But we'll keep putting the integrated performance reports into our board packs, so we've got that point of reference and triangulation for any future use.
I think just on that, I think to support the wider team, I think there is a piece of it. I think first of all, let's recognise the IPR is in a much better place. Yeah. I think it's now giving everyone a clear sense. I think what we're saying is there is one last hurdle to get right, which is we reproposed our population outcomes framework, yes, but we did disband the committee, and we did therefore put those into the other committees. So I think it is important that we're clear for anything related to health inequalities and population outcomes. What is the ExCo's role? What is the QPEX role? What is the FOC role? Just so we can be clear, there's nobody else thinks the other one's doing that piece of work. So I think if we just do that one last run around again, I think we know where it should be, but I think if we're still having the discussions here and are concerned, we just need to make sure that we're happy that that's been picked up at the right place.
No, that's helpful, Adam. Okay, so as a board, we're asked to note and take assurance from the content of the report, and we just need to confirm that we are assured. So I think we're assured that actions are being taken on all the items that have been raised. Okay, so we can note that. Thank you, Kerry. So let's move on to the strategic planning items, and I'm particularly pleased to welcome Dr. Oliver Dale, the new, relatively new Chief Medical Officer of Sussex Partnership NHS Foundation Trust. Oliver, you're very welcome, and you're here to support Amy in the delivery of the coming paper. Now, we have two papers that I'd probably like to consider together, if that's okay, colleagues. We've got one on delivering our strategy, improving lives together, and that's got a real emphasis on integrated community teams and a population analysis of our major services. And that's from page 224. We've also got then the NHS Sussex Commissioning Framework to support that delivery from page 240. And in many ways, I see this as two sides of the same coin. So what I suggest that we do is, I suggest that we take the introductions to both papers, one after the other, and then we have a combined discussion over both papers, because I think you can't really look at one without the other, is the way I think about it. So on that basis, Amy, can I maybe ask you to maybe kick us off in terms of, you can assume the board has read the papers, but any specific points you want us to focus on today, and then I'll go to Oliver, and then I'll come to you, Claudia.
Thank you, Chair. And I just want to start off by saying that clearly delivering our strategy requires the collective effort of all our providers and partners in the system. Therefore, the work that's presented in this paper is the combination of everyone's efforts. And it's here because we wanted to do two key things. One is to show the continued progress we're making around developing the integrated community teams model that the board has previously been appraised of. And you'll note that we're focusing this year on 2 key areas to help us bring this model to life, which is around supporting people with the highest needs and also implementing our neighbourhood mental health team offer, which Oliver will speak about in a second. The other key thing, though, that this paper does is that in order to really accelerate and implement this offer, we do need to fundamentally rethink and reimagine how we deliver all health and care services across our system. And that's very congruent with the government strategy and 3 missions that we have heard about from the Darcy review. So in some ways in Sussex we've been a bit ahead of the curve in thinking through how we implement this strategy, and we do want to go further faster, because I think it's fair to say that an independent review of our services so far indicates that if we do nothing, we will not be able to meet the current demands on our services. And it also points to the fact that although many of us are working very, very hard, the experience and outcomes from our services isn't as we would like it to be. And there is more that we could do from a preventative aspect of care to really support people better within our communities and to improve the experience of care. So this paper presents that case, and then, as you said, it also signals that our role as strategic commissioners needs to fundamentally change, which Claudia will touch on in a bit. But before we go to that, I thought it would be incredibly helpful to hear from Oliver, who has been on the integrated community journey with us right from the start, and also has pioneered our work around neighbourhood mental health teams. So,
okay, thank you. So I'm also going to talk a little bit about my work before I came to the system, because I've been on a bit of a journey around the integration of care. I'm going to try and give it some sort of flesh to the bone, as it were, and some actual real-world detail about what this means. So the ICT programme is about creating, as Amy said, an architecture for a multi-agency approach to how we organise services. And it effectively integrates, and I will explain this a bit later, horizontal and vertical. It delivers horizontal and vertical integration and drawing on local leadership, and through developing shared governance and data approaches and so on. The neighbourhood mental health teams, they are effectively the Sussex iteration of the community mental health framework, and their history goes back a few years when the ICS commissioned SPFT and the VCSC to set up a programme of work. And they are the way in which we're going to deliver this sort of approach for working age adult mental health services. And the reason why it's a really important clinical area of focus for the ICTs is our health inequalities for people with serious mental illness is very significant. On average, people with SMI die roughly 20 years younger.
And SMI is severe mental illness. Exactly. And this is and they largely lose their life through preventable conditions. So that's why it's a very important area of focus for us. And the other thing is that from a prevention point of view, one of the ways in which you can really have a significant impact upon people's outcomes is through having a responsive service where there's good continuity of care. And continuity of care is one of our most powerful weapons in trying to address people's needs. And it's been demonstrated to reduce admissions, investigations and all-cause mortality. So this is about trying to create local neighbourhood teams where continuity of care is maintained. In order to start this process, though, because this is fundamentally a complete redesign of adult mental health services, and it's going to take a long time, it's going to require an enormous amount of engagement and relational work in order to get these services up and running. And so we've taken a very iterative approach to this model. And effectively, over the last few years, we've established 3 different elements of the model. The first is an emotional wellbeing service, which is a combined SPFT VCSC service operating at a PCN level, which is responding to people with common mental health difficulties and facilitating some short-term work or possibly escalation into secondary care as required. We also have access facilitators now across the entire system, and these are people who are actively engaging those who wouldn't typically respond to primary care's attempts at engaging around physical health assessments and so on. And so they're providing literally thousands of physical health assessments at present.
We've also developed something that we call the multi-agency triage hub, and this is where we bring different partners together. And this is a really, one of the difficulties we have is how when someone is, when a GP is asking for help, sometimes they might not knock on the correct door because it's a very confused landscape. And so part of our approach to simplifying that landscape in order to ease people into services and reduce duplication and confusion is to create a multi-agency triage hub where basically referrals can come in and we can work out who is the best provider for care for this particular individual. Jumping ahead, what we're doing right now is we're actually bringing those services together, and we're amalgamating them with our assessment and treatment service, which is effectively our traditional secondary care community mental health team. And we're bringing those together to a single team operating in an ICT footprint. Before I came to Sussex, I worked in a similar sort of model. We developed a similar sort of model. And what this meant was we were able to have clinics embedded in our GP practices, and we would have multi-agency conversations around individuals at a GP practice level, where my team and I would join them, some virtually and others present with the GP, and we'd also see patients together. And sometimes this would completely prevent a referral in the first place. And I'll give you a clinical vignette just to try to bring this to life a bit. Quite often we discharge people with complex mental health difficulties, and we will ask the GP to continue medication, sometimes without any further review from ourselves. And they may take that medication for many years, but sometimes they may see what it's like without medication. They may want to stop it. And there was a particular patient who, in the GP practice, who had stopped the medication and who had become unwell. And in the old approach, they would have been referred into our triage hub, and that would have taken some time for them to be triaged. And then they would have been referred on to our secondary care mental health team, and they would have seen a practitioner, and that would have taken a bit more time as well. And we would have been lucky to have seen that patient within 4 weeks. And it could well have been longer. And in that period of time, there would have been an extremely high chance of that patient deteriorating and becoming unwell to the point where they would escalate and may require emergency treatment, possibly even an admission. As we were embedded in that practice, we were going to the practice the very next day. The GP said, "Why do you come back and see us the next day?" So we saw the patient there and then, restarted the medication. No referral was ever made. So it's a very different way of working. And this is something that I think is something that is applicable to all specialties. But in mental health, it's obviously where my passion is, it is really a very different way of working. And as a clinician, it was a much more rewarding way of working, because I'm not having to deal with bureaucracy. I've got a lot more information there and then in making decisions, and I've got colleagues by my side as well. And the other opportunity is that it allows us to broaden our skills mix, because you have got generalists and specialists working alongside each other, and it's a much more sort of creative way of working. People feel stretched because they feel confident to make the decisions which they may not necessarily do if they weren't working alongside specialists all the time. So that's the sort of way we're trying to get to. The neighbourhood mental health teams is a particular clinical area of focus, I think, for the ICTs, and it's illustrating how actually ICTs can develop. We're also talking about similar approaches for frailty, because that's quite an obvious area that we could think about. But I'll be quiet, I'll stop there, and I hope that helps us bring it to life a bit.
Well, yeah, but certainly thank you, Oliver. I think I'll say thanks at the end as well, but bringing it to life from the clinical perspective is incredibly powerful. So thank you not just to you, but I know there's a lot of colleagues within Sussex Partnership Trust are working on this. So thank you to you, to Jane, and all of your other colleagues too. We're just completing the set introductions to the paper. I'd just like to come to strategic commissioning and the framework that you put in the paper as well, Claudia. Any comments on that?
Yeah, thank you, Stephen. So I guess it's really clear from the paper that Amy has referenced that redesigning our services to better meet the current and future needs of our population is really critical, and particularly in support of delivery of the system strategy. And I think the piece that Oliver just described about what difference those different clinical models of care can make in terms of improving the lives of our population is absolutely key. If we're going to deliver those new models of care and redesign our services, commissioning is fundamental to that.
Yeah.
And we as the ICB are accountable for ensuring that our healthcare services are arranged in a way that best meets the needs of our population. So strategic commissioning and our role as a strategic commissioner is fundamental to the delivery of what we're talking about and the transformation of services. That has been behind a lot of the change that we've done as an ICB over the past 12 months. So it has underpinned our restructure, our target operating model. We brought the strategic commissioning policy to the board back in May, I think, of last year, which described from an overarching perspective what we were looking to achieve. The further evolution of that has been the development of the commissioning framework, which we presented to the board today. The purpose of the framework is really to ensure that our teams really do work in a multidisciplinary, holistic way around the delivery of strategic commissioning. This does not just sit with commissioning teams, it's about how our clinical teams, our finance team, our workforce team, how all of our teams work together to successfully commission the kind of change that we're talking about. So it really is fundamental to us as an organisation, and that framework is key to supporting our staff to understand that, as is the work that we're doing through the Commissioning for Improving Lives Together piece, which is the whole organisational development piece for us as an ICB. I think the final bit just to touch on is set out in the paper, which is the need for, what we're proposing is the need for a strategic commissioning roadmap, which really gives us that clarity over what we're going to need to deliver in the next 1 year, 2 years, 3 years, that then enables us to align our resources to successfully commission those changes and make sure that we're set up as an organisation to succeed.
That's great. And certainly through the framework, Claudia, it's very clear the multidisciplinary nature of that, and I thought that was really, really explicit. And it was a key part of commissioning for Improving Lives Together, a key part of our conference that we held with our staff recently. So it's good to see all the things all having a very consistent message to all of this. So just before we open up to questions, I think probably we should always start thinking about our population. And bearing in mind we've got Alison Challenger here as our Director of Public Health and representative partner Public Health on our board today. Any perspectives from you in terms of the approach that's been taken to meet the needs of our population, Alison?
I think one of the big things that we've done is understand what the needs of our population are, and we've done that to a much greater extent than before, where we've worked together as partners here. We've looked at all the available data, we have appropriately shared data to get better understanding. So I think we are in a much stronger position, both at system level, place level and at neighbourhood level, to understand what the different needs are across the whole of Sussex. And that gives us a good starting point for what we do in terms of planning services. And thinking about also the population outcomes framework, that is another piece of work that we've done in Sussex. And that's really to understand beyond the usual metrics, how we're thinking about outcomes in the round. And that includes clinical outcomes, but it also includes public health outcomes as well. So what that allows us to do is think about the whole journey, thinking about the prevention and how we might prevent need for health and care in the future, and bringing in some of the public health prevention services as well, for example, and how do we work in conjunction and think about commissioning across the whole of that piece. So I think it allows us to support the population for the whole of that journey, rather than just thinking as a treatment and care. So I think the whole approach to integration and understanding the needs will help us deliver much stronger outcomes.
Great. Oh, well, thank you for that. Okay, colleagues, so we've got a lot of information here to digest, but who'd like to kick us off? Louise.
Thank you, Chair, and thank you very much, Oliver and Claudia, for your introductions. So we've done the needs analysis, and we've looked at the existing market of providers, or we're going to look at the market of providers. And we need to get to a position of having integrated community teams from that existing market, or do we also need to do market shaping in order to create the optimal team?
So, Claudia?
Yeah, so I think depending on what the changes that we're looking to deliver, I think that's your starting point of understanding what the change is that you're looking to deliver and what that market already looks like. There might be areas where you do need to do some sort of market stimulation to ensure that we're really challenging everybody out there around what is the best model, and how do we really encourage transformation and innovation as part of that. And that benefits, I think, our existing providers as much as it does anyone else wanting to come into the market. So if you can be clear about the change and the service change that you're looking to deliver, the outcomes that you are looking to commission, you can then be much more flexible and allow more flexibility in terms of the proposals that come forward and encourage the level of innovation that you really want to see.
Okay. Do you want to come in on that?
Yeah, I think we should just make sure we're being as clear as we can be across the board here. So, what have we done so far? We have a case for change that says, which we've agreed across all our system, that said things can't stay the way they are. So it's quite profound what we said. We said we then also create 16 integrated community teams. I know there is now a debate about the number being now 13 with our change in Brighton Hove, but the model is still prescient. We said that the only way to improve population health was to deliver those teams. We put a framework around that together as a board and done that in partnership with everybody. We've agreed those localities because we believe that's where the population live, rather than how historical NHS services have been configured. So we've said that quite clearly. And what I'm really pleased about in the paper is it frames the work that is happening in all those areas collectively. So we're already starting to do stuff differently in the 13 areas. That needs to move at a significant pace, but in the current financial environment that the NHS finds itself in the current issues you've got regarding clinical fragility, we have to think differently about the model of care by which that gets delivered. So in the 16, now 13, we need to have, as Oliver has really clearly articulated, that for everybody and not just for mental health. So that's kind of where that's where we've got to get to really fast. That creates the left shift. That creates the shift to prevention. That creates a neighbourhood health model. So that's what we have already agreed to do. The additional part of this, it says though, however, the NHS, and I use that quite purposefully now, the NHS needs to look at where it does its business in Sussex. And the process we're going through now with our providers is saying, what do you think about that? Over the next 5 years, this is the population profility that changes. Where is the best place to therefore deliver health and care? With the mantra that we all want to have more care in the community and less acute care where we can avoid it. So that's our piece. We're doing that at a time of significant public sector financial constraint, so we can't avoid that. So we've got to do that with our local government partners, not against them, because the only way to do it is to do this in collaboration as a unified leadership community. And what we're saying as an ICB, we are going to be a strategic commissioner, and the framework is that. So what it actually means is we want to work with everybody, our communities particularly, then also our clinical teams to therefore ensure we've got them working in the right way. But alongside that, we have to also be really clear that we're the commissioner now. We want to work with everybody really well and positively, but where we think that things need to change and the market is not available to therefore respond to those needs, we have a job to stimulate it and to manage the market. So therefore, we want all of our NHS organisations to respond really well, just because why wouldn't we? But we have to preserve the right that they can't. What do we do therefore next as a leadership community to therefore get that piece right? And I think what I'm really pleased with what the work the team have done is sets out the milestones over the coming sort of period. So the things you should be expecting to see as a board on a regular basis that cover off, these are the areas we're going to. So I think for us, it's really important, Louise, to your question, that we do look at the commission framework, because it really sets in motion quite a shift for how this organisation operates, and it will create quite a shift in maybe how we approach the provider sector and also how we approach the other people who could be providing care to us locally. The last thing I'll say, then I'll be quiet, is this change is profound. So it's just important that we don't underscore what we're actually saying here. And we need to develop options for what that can look like and what that therefore means. And over the coming weeks and months, we'll describe what those options look like. But this kind of sets in motion now. We've said we're going to do this for quite some time. Here's the how we're going to do it. And to do the how means to make choices and decisions about where we think we should be placing services across our system if we want to deliver the left shift. So, sorry to come in, but I thought it's going to be orientated in the history and also where we're at currently.
I think that's really helpful, actually. And I was going to bring you in, Mark, actually, because I think the reality is, the NHS cannot do this on our own, is the reality. And I think it's not just local government, it's also the voluntary community, social enterprise sector too. But what's the perspective from local government, Mark?
Thank you, Stephen. Just to add to that list, I think it's also people themselves as well. And I think one of the things we need to do is try and inform and support the population to help manage their own health. And I'll come on to why. I mean, these two reports are fantastic, aren't they? And I have to say, Oliver, your description is really compelling, isn't it? I want to get out there and get on with the rest of it now. I think distilling the two reports into probably two key elements: the population profiles. The figure on page 227, I think if you look at the colouring in it, it doesn't make for great reading, and it's an indication of the challenges that we face in Sussex, but also the differing parts of Sussex and the narrative above it, which I sort of live and breathe in terms of the ageing population that we have. 26% of our population in East Sussex are over 65. We have the highest over 85s in the country. So where we lead, others will follow. But that presents real challenges, and I think Alison's point about we actually really understand our population a lot more, and I keep going on about the ICT population profiles and how different they are and how much information they give us is really helpful, particularly in the context of the financial challenges that Adam has mentioned, which faced by the NHS and public services to varying degrees. So we've got these two competing things about our population need and the money going down, if we're lucky staying the same. And this is where the commissioning strategy or the strategic approach to commissioning comes in, because we've heard it before, but doing more of the same simply isn't affordable, and looking at the outcomes, not hugely effective in terms of supporting the health and well-being of our population. So really welcome the approach. I think there needs to be huge focus on prevention at that early stage. I go back to the comment about informing and supporting the population to start managing their own health and well-being. That's probably the easiest and most cost-effective way. I think there's also something about joint commissioning that we need to take forward. Given the limited resources, it's incumbent upon us all to make the best use of the collective resources that we have, so would really welcome a discussion around that. And the approach, the combined approach to stimulating and supporting the market to give us what we need going forwards, I think together would be more powerful and more effective than separately.
Great. Okay. Thank you, Mark. And I'll be honest, I'm a member of all three health and wellbeing boards across Sussex, and I've been struck by the enthusiasm from other colleagues and other parts of the system, the wider system, towards integrated community teams. So this does not feel like an NHS initiative. This does genuinely feel like a Sussex health and care system plan for the future of our population. So it really does feel quite tangible, but we've got to execute it and we've got to make it a reality, I think is the reality. Okay, Christina.
Thank you very much, Amy, Oliver, and Claudia. My question is going to be around the 69 CUTs coming down to 30, 4 in Brighton down to 1. We know that Brighton is quite a dense populated area, and it has different demographics. It's got the homeless, it's got sort of mental health and is high on the preventable mortality rates by ICT areas. And my question is about what was the level of engagement that took place to arrive at the decision to reduce it from 3 to 1, and what would that then, how is that going to impact those different groups spread across the area, because Hove is completely different from Brighton.
Okay, I think it's a good question. Amy, why don't I come to you, and then maybe Oliver, you can bring in your experience from the mental health perspective as well on that.
Absolutely. Thank you for the question, Faustina. So the conversation about the number of ICTs and how that broke down in Brighton and Hove was a conversation that started at the Brighton and Hove Partnership Executive Group, which includes all system partners. So it has representation from the voluntary sector, from primary care, from our community trust, our acute hospital, and also our local authority colleagues. The conversation started there because there was a recognition that it was proving challenging for the teams that need to come together to think through how they can deliver services for the Brighton and Hove population in a fundamentally different way. And that was linked to conversations that were going on in the mental health space as well, as we started to develop the neighbourhood offer for mental health. System partners thought that it would be helpful to go to kind of one community team model to align with the local authority boundaries, as we have done in West Sussex and East Sussex in terms of lower tier kind of authority boundaries. And there was recognition that although there might be a single hub where teams come together, the delivery of services would need to be more dispersed to recognise the variation of needs of the population. So the Brighton model has what are called 3 spokes. So there will be 3 teams that deliver services across West, Central and East. And also there will be an outreach offer, because there is recognition that in some pockets of Brighton there are significant areas of deprivation where outreach is important. So once the executive of Brighton and Hove kind of came to a consensus around this, there was a presentation of that recommendation to the System Oversight Board, which brings together whole system partners, and there was endorsement of that model, and then that went to both the Health and Wellbeing Board in Brighton and Hove and subsequently the Assembly. So there was broad engagement in reaching the final conclusion, which was a decision taken ultimately at the Assembly.
And it might just be worth just bringing in all of it at this moment, because obviously the initial intention was to have 4 integrated community teams, but actually that was proving very difficult to work operationally. And could you just maybe just, in a minute just sort of explain what that difficulty was?
So there is probably a number of a population level where you need enough people to organise an actual spoke, a team itself, and for mental health that's probably around 100,000. So we will be moving from 2, currently we've got 2 teams in Brighton, and we will be moving to 3 spokes.
But 3 were subscale compared to the 4 that we were planning to try and achieve. So that was the difficulty, I think, wasn't it?
You need a critical mass basically to make these teams work.
Yeah. Okay. So that's the proposal. It's so does it address your question on density though, Faustina?
I would wait to see how it will be evaluated, maybe in 6 months to a year's time, to see if that is actually really delivering what the population the impact of that.
All right, thank you. Alison, you want to join?
Yeah, it's not a question really, it's just a comment and a reflection really, just about how fantastic these papers are actually, and having worked in the system for quite a significant period of time, I just wanted to acknowledge the significant amount of work that's happened, but also really recognise the commissioning framework and what that will do in terms of helping our workforce really understand what their role is within the strategic commissioning context. We've been trailing what the ICB's functions have been with our staff for a very long time, and I think what this does, because they've been involved in the development of this, it really helps in terms of our journey as an organisation, and help support them in their individual and team development, so they're really clear about what we need to focus on as an organisation. So it was just to offer that perspective, Chair, in terms of you know, this is a really good piece of work, and as we move forward with the new operational framework and the roles of ICBs and providers in NHS England, I think this will stand us in great stead.
Yeah, I think that's very helpful actually, and I think if you think about it, we have restructured our entire organisation of 800 plus people to deliver that framework. And we should not underscore, these are a whole series of things that are starting to come together. You know, that's quite fundamental. Rahul, I think you had a question, and then we might need to move on.
Thank you, Chair. Yes, I guess it's a more general question based on our experience of working in adults and I guess psychiatric liaison with a GP practice versus other services that could be offered at an ICT level. And what you think the challenges might be in terms of collaborating on a care pathway versus real partnership or consolidation in providing a service and communicating out to the population that this is a new way of consuming this service.
Okay. Oliver,
yeah, so there are a number of enablers, I mean, just to pick out two, which I think are really quite key. One is around ensuring you have local leadership. And that local leadership relates to the equivalent in all the different organisations. So at the moment, with the within the collaborative, we're working effectively on an organogram which matches up so that we've got the right people at a local level to be making decisions, because there are inevitably bumps in the road that need to be managed and contained. And another enabler I'll just pick out, which I think is a game changer, and it was my experience in my last place of when we adopted the same electronic patient record system as our GPs. So we are working on that, and that is a really, I can't underestimate, you know, it is a very significant change. So instead of being blind to the information that the GP had, if the referral wasn't quite up to what we required, we had the information there and then we did not need to go back to the GP. Also, if patients were presenting in an A&E department in the north somewhere, it would come immediately through to our system, and people could see in real-time triage discussions and so on. And that really knits together things and informs the relationships enormously between one another. And I think the other enabler is going to require a lot of encouragement, because it's a big cultural change, and that is getting clinicians in the same room talking about their patients together, that learning you get from one another is self-reinforcing. But it's that's a significant leadership challenge. But I think there's a big carrot to dangle for our clinicians here. So I think it's doable, but it is going to require us steering the course.
This is not easy, I think is what you're saying.
It's not easy, and it's going to take time.
Yeah. Okay, I think that's helpful. Claudia, do you want to have a final word on this?
Yeah, I think so. I think the papers set out the huge opportunity that exists for us as an ICB, but also as a wider system around service transformation. They are described as strategic change. That doesn't mean to say there aren't changes that can be made over the next 12 months. And the analysis that's being done gives us a really helpful indicator of how, when we look at how we use resources next year, where we need to focus our efforts, how we can make those better informed decisions to use the constrained resources that we have to best meet the needs of our population. And we can hear from what Oliver said, there is already change happening. There is change that we can progress in this space over the next 12 months, and that will be part of our planning.
It's not all long term, we can do some things short term. And Hannah, use of resources, I suspect?
Yes, it follows what Claudia's going to say. I mean, this is brilliant, isn't it? It's exciting stuff, and it's so important to the financial sustainability of the system and for our patients and population. As you can see from the data in here, if we don't do anything, just how much the growth in activity is going to take place, which, you know, quite frankly, is just going to be unaffordable as a system. So this change is great for patients, and it means that we can be financially sustainable. So put better services in place, as well as being cost effective and using the public money in the right way. So important, really exciting stuff.
Great, thank you for that. I just had Amy.
Just one final comment, because I think it's important that we don't lose sight of the next steps of this, one of which is that the clinical leadership group across the system We'll be discussing this just next week,
Yeah.
and we will also be co-developing with them the engagement process to really start to understand how we prioritise the right service areas for improvement, and also how we then start to co-design the services. And we've started a good way of doing that in the ICT programme, and we just need to now take it forward at pace to look at the whole system improvement and change that we're looking to achieve.
Right. I'm detecting a huge amount of enthusiasm for the programme of work in Sussex. I just had one small question, bearing in mind actually we also need to be aware of our government and Department of Health and Social Care are working with NHS England to develop a new 10-year health plan. And I just wondered how, what the next steps were in terms of engaging the population, not only in this, but in alignment with the 10-year health plan. And I wondered, Mark, whether you could just pick that one up.
Absolutely, thanks, Stephen. Well, for us, this is a perfect moment to be doing that, because not only have we got this in terms of our plan, we've also got the National 10-year plan. They're concordant with one another, as has been described. What we'll be working through is to bring something to our committee in common on the 11th of December with regards to our next 6-month plan, and making sure that these are not seen in separate isolation of one another, but are conjoined engagement events that will start in January.
Okay, so the part to address that. Louise?
Thanks, Stephen. May I add to that? With my other hat on as co-chair of one of the vision groups for the 10-year plan, we're incredibly lucky to have Amy also on that working group. And actually the work that is being done here is in many ways going to be informing, I think, what some of the national approaches, because I think we're quite far ahead. And in terms of public engagement, what's already been fed through to our work stream against the three big shifts is that the big shift that people want the most is care closer to home.
Yeah.
So this is manifesting that effectively.
It is. Okay, that's great. Adam, I want to give you the last word, then I want to go through pedantically what we've agreed.
So, really helpful, thank you. So, first of all, really good discussion. I think it's just important, I'm going to re-amplify again the size of this, just as no ambiguity. So what we're about to do is embark upon the next phase of a journey we've been on for quite some time, that is now about fundamentally changing the model of care in 13 parts of our system. It therefore means a fundamental change about what we might think happens across other parts of the NHS locally to achieve that aim. We cannot do it without being in partnership with our communities, so therefore it is really important that that the plan we now put together about how we engage people meaningfully on this is really key. The other key part we have to get right, and I cannot underscore this heavily enough, as a clinician, I can make a choice today with a patient to do something that takes us towards this strategy or takes us away from it. How do we ensure that we've got all of our clinicians who are seeing patients today that are going in the right direction? And let's be very clear, whilst we've done so many things to improve our health and care system here, we are not known to be the most clinically led system in the country. To do this change, we're going to have to become that. So it is important when we say we're bringing the clinicians together, I think you should challenge us back to go, how confident are you in their work together to actually respond to this? Because that's the key part to get right. So that's why both James and Alison will be working very closely together with the wider clinical leadership community about how we therefore tackle this. And then the last bit I think which is important is this throws up some quite clear things that can be tackled today, like the outcomes of people with cardiovascular disease. So it is important that we see, as to Claudia's point, there are things we need to do in the long term, of course, we can't do in 5 minutes. But there are things that are challenging us now. I think our challenge should be, if we're going to deliver a shift of care to the community, wouldn't it be great if our community started to see things shifting now?
Yeah.
So therefore, when we start to shift bigger things to the community, people have got confidence built in us that we know what we're doing, we know how to do it, but most importantly, it is being led by people they trust. And in the National Health Service, that tends to be our clinical leaders and clinicians working the front line. So how we galvanise them to do it, that is the key challenge we've now got to take forward.
It is. And actually, in fact, we've already asked James in the forward plan to come back to our next board to specifically talk about how we're going to improve cardiovascular outcomes for our population. So this is not something we need to wait for, this is something that we can crack straight on with. So that's on the forward plan that we'll come to. Okay, colleagues, so as a board, for the Delivering Improving Lives Together paper, we're asked to note the progress made with respect to delivering Improving Lives Together. That's our strategy, most notably the development of integrated community teams. We're to note that the Sussex Health and Care Assembly approved the change from 4 integrated community teams in Brighton and Hove to 1, and actually the strategy is owned by the Assembly, not by this particular board, and that's to mirror the local authority boundaries. To note and consider the independent analysis that has been undertaken and which the board has been exposed to before in terms of population health needs, and to endorse the next steps which involve exactly what Adam was describing, the genuine, real, deep clinical engagement with our confidential group and then the immediate work on cardiovascular disease. So can I just check that everybody is content with that? Because of the importance of this, I'm also going to ask the reverse question. Is anybody not content with that? Because this feels a really important moment that we're all signing up to this unanimously. Yep, okay. I think we can therefore say we noted and endorsed unanimously. Kerry, thank you very much. And then on the NHS Sussex commissioning paper, we're asked as a board to approve the framework that is in the paper and to approve the proposal to develop a multi-year strategic commissioning roadmap, which again Claudia mentioned, and the underpinning programme of service change delivery by March. Can I again just check that everyone is content with that? Because of the importance, is anybody not content? No. So again, I think we can say we've unanimously approved that. Sorry to be pedantic, but that is a really important component. Okay, thank you, colleagues. That's very good, and thank you very much for the huge amount of work that's been done. Oliver, I know you need to go, so please feel free to depart. But thank you very much for joining us today.